So, it gives me great pleasure to introduce my colleague and friend from Bath, Stewart Redman, who is going to give us the poster highlights lecture. I'm told Stewart is back by popular demand. I didn't see where that came from, but I'm told it's true. So Stewart, thank you very much for giving up your time to look at all the posters and bring them to our attention. And a hard act to follow. The floor is yours.
Yes, thank you very much. Good Lord, there's a lot of people here. I've given the poster highlights talk before virtually, and it's normally just me sitting at home alone, talking at my screen. I've no idea how many people are out there, so I'm feeling slightly agoraphobic. Thank you to Val for that wonderfully well-told, in-depth, coherently put together story. This is going to be the kind of opposite, really. It's a collection of short stories put together, and it's meant to entice you into the posters. There's something there for everyone, and so I really do encourage you to go and have a look, find the little nuggets that will just make you think about your practice, what you do, how you do it, how you could move the specialty forward a bit, how you could move your department in your service forward. I've got no declarations of interest. So we've got 71 posters out there for you to look at. They're from all over the world, and I've got a few of those international ones I'm going to show you now. And they're from across all the staff groups. So as I said, something for everyone. Okay, so let's get into a few of these. So here's a poster from Hull. This is a hot topic. We had a session this morning that I imagine some of you were attending on whole body SPECT-CT. It's a kind of developing area. Lots of people want to get into this. There's some nice data here. If you are thinking about setting up or starting to do whole body SPECT-CT, I would commend you to look at this. It just has some good data about the problems you might hit and some of the issues and challenges along the way. And Hull are moving nicely down this line to what looks like a coherent service with areas they're going to improve further. And they comment, it is resource heavy across all staff groups. So getting a clear idea of which patients would benefit is an important next step, really. And certainly we found that in Bath. We've got the benefit of a 360 CZT that can do this, but we're still in that resource question. Who should be getting this? And we don't know. So anyway, if you're setting up service or thinking about this, go and see the poster, get the detail. Fine, so this is from the local technologists in Glasgow. I had the pleasure of having dinner next to a couple of the local technologists. I don't know if you're in, I can't see, last night. Thank you very much for your hospitality in Glasgow. That's not the sole reason I put this up here, but anyway, thank you to Glasgow. This is white blood cell scans following knee replacement, and they've looked at 5 different techs putting regions of interest on, and found that there is some variability there, and they're moving forward to standardize that, and I think that will help the presentation of the images and how these are reported. So important work, and something that I'm sure lots of other departments could think about. So this is from Newcastle University, George Petrides and some of his colleagues, F18 choline, and there was a great session yesterday on parathyroid imaging, with choline certainly being a really valuable part of that. And this data that's presented is similar to that was presented yesterday, really. So these are patients who've failed surgery, you can't find the lesion, and they found 64% they found targets, which is very good, and all the ones they've operated on so far out of that group have been cured. So we've done a few of these in Bath, but the funding has kind of dried up. Alliance kindly aided us in doing a few, but now we can't do that anymore, and I think a lot of other sites are in that same position. George from this group, and I know Richard and a number of others have contributed to a national submission for national commissioning of this, which hopefully will be coming to fruition soon. I was looking at Richard to see if there's any update. He's got his arms up and not yet. Anyway, we shall keep, as a BNMS, pushing on that door and trying to get this commissioned. So Birmingham seems to be the kind of national centre for GI imaging, and it's good to see them putting another poster in this line. This is HIDA scans, and I just thought it's a nice little message to us all. You've got similar results, but for two entirely different reasons, and it's just a nice reminder to you've got to think. There's a great thing about nuclear medicine, often in radiology, which is the other thing that I do. When you're reporting, the answer's there. You either see it or you miss it. Whereas in nuclear medicine, you've got that, but you have to do the secondary thinking to get the answer right. And it's an important reminder to gather all the information that's available to make sure you get the right answer. So there's a number of reasons I put this poster in. I like this poster probably more than most people here, so it's a kind of me thing. Firstly, it's kind of old school. This is using gallium. A lot of us have moved to FDG PET-CT for looking at infections, but this is quite nice. And in the skull base, particularly next to the brain, I think this could be used more, kind of have more widespread use, something that we should think about. Returning to old radio tracers is something that I think there is quite a lot of potential in. This is a really nice revision of anatomy and pathology, and it's very pretty. It's nice to look at, which I think is important in a poster. It's from my colleagues next door in Bristol, which is good to see, up the West Country. And it's even from the lead author who is currently now with us in Bath as one of our trainees. So there's about 5 different reasons why I like this poster. This is from Leeds, and it's a good data set over 10 years looking at vasculitis in FDG PET-CT. Again, this strikes out to me because it's something that I report, and you've got polymyalgia rheumatica and giant cell arthritis, and they can, and often you just get in your head, you're going to do kind of, especially put in your conclusion one or the other, and it just reminds you that these two things coexist, and actually using the EANM kind of qualitative grading helps you to get it right and get better information in your reports. So I thought this was nice. So if you're a PET-CT reporter, I would commend this to you. So this is a poster that's come all the way from Zagreb, which is nice. Thank you for attending the conference, the team from Zagreb. Again, it's very pretty, very nicely put together, so well done. So this has got lots of different facets within it, but the one that stood out to me, the positivity rate of the Ga-PSMA scans was heavily influenced by the PSA doubling time. So if it was less than 6 months, so the tumours doubling quickly, then 70% of those were positive. If it's more than 12 months, that rate fell to 22%. Interestingly, there was another poster, which I haven't put into the highlights, but was equally good, just trying to get a breadth of things, which didn't find that in the PSA doubling time. So I think there's more work that's required here, but it's interesting, and I would like to think the PSA doubling time is something that we should be looking more at. Mediastinal lymph node positivity on FDG PET-CT scans. Again, it's a nice data set. There's you've got nice graphs there. They've got a lot of data here. 52 patients with histopathological confirmation, which is, so this is a pretty good data set. And they looked at a number of things. Again, if you're interested in this area, I would go and read the poster in depth. But interestingly for me, the nodal SUV max, which is something that I would be looking at, is good at predicting positivity. But if you normalize it to the tumor mediastinum and liver, it's even better. So something that I myself will be looking at. Something else from Bristol here. So I'm keen on us working together, being more collaborative, using the skills of teams not just within our hospital, but looking at teams around our region or country. And this is a good example of that. This is a case from the height of COVID, where they didn't want to transfer the patient, so they did the specialist scanning with the help of the specialist unit in their own hospital, and meant that the patient could carry on down their pathway despite the first wave of the COVID pandemic. And for me, the take-home message is that idea of cross-center collaboration, of working together and helping each other. So, yes, well done. So we do, for our Sentinel Node breast patients, we sometimes do a one-day protocol and we sometimes do a two-day protocol. And this is something that crossed my mind. Is one better than the other, and should we be doing one or the other? Really, our 1 or 2 day protocols are based on logistics, because these things are, again, multiple teams. You've got to get aligned with theatre. They're difficult to fit in. And so having that logistical flexibility is very useful for us. So I got a bit nervous when I was starting to look at this. It's a good data set, 300 plus patients, and they've got overall survival data as well, which is another thing that we don't often get in our imaging studies. And it showed no statistical difference in either disease-specific survival or overall survival if you use a 1 day or a 2 day protocol. So that's very encouraging that we can carry on doing one or other of those protocols depending on which logistically fits the best for us and the surgical team. So it's another local poster from Glasgow. Thank you very much for putting this in. And this shows the benefit of working across multiple teams to try and get good outcomes for your patients. So the standard kind of national guidelines would say that you should do dynamic imaging and then static SPECT-CTs. They developed a protocol that was just the static SPECT-CTs, and they've done a number of these over a number of years with good results. And I think the reason for that is local kind of close working with the surgeons to get a really high quality service, which is kind of more important than the national guidance. So we've got something on dosimetry from Southampton, and I think this was alluded to in the last talk. I'm sure this is probably the same team as Val and my old stomping ground. And there's something on this more in depth. I think there's a talk tomorrow. I don't know if that's from the same team, but looking at using single time point method for dosimetry in lutetium rather than multi-time point. And one of the conclusions, there's more to it than I'm telling you here, so go and look at the poster, but one of the conclusions is this might be appropriate in the palliative setting to stop multiple trips to the hospital for dosimetry, and you may be able to select patients from your one time point. Some people will need further multi-point imaging and some people may not. So this could be a real benefit of patients who are having multiple trips to the hospital. And time for the staff as well. Yeah, so I like this. This is, there's a Mannikin that's been developed for testing your probe skills for sentinel lymph node biopsies in the head and neck. You can see there, it's a very pretty Mannikin, and it's got lights that shine out of it to show you where you might be going, and you can load it up with radio tracers and practice to your heart's content, and it gives you good feedback. And what I liked in the conclusion was users found it fun to use, and there's a little message for us: don't forget the fun in life. We all need to search for that. So Again, this is probably a me-specific thing. Oh, and some physicists in the audience might like this. But this is radiation protection. I'm also the radiation protection lead for the Royal College of Radiologists, so spend time thinking about this kind of thing. And this is developing local DRLs, but not just broadly for SPECT-CT, but making sure that the CT DRLs are anatomy-specific, because you're going to give a different dose to just a neck than you are to an abdomen or a pelvis. And so it's just thinking that and working in your own local DRLs. So I certainly don't know the answer here. This isn't telling us an answer, it's more asking us a question. So they found, there's a few elements to this poster, but one of the things they found was there's the subdiaphragmatic interference in cardiac studies. They found that that was more likely in fasted patients, and you were fasting them to make that less likely. And that goes against the published literature, and it was significant, and they've got reasonable numbers. I've no idea which is the right answer, but what I do like is that we're questioning the evidence, questioning what we know, and that should apply to lots of areas of what we do. We should always be, not always taking things on face value, reassessing what we do, how we do it. Is this the best way of doing things? So it's just a nice reminder to keep questioning. So a diabetic fasting process protocol. This is from Belfast, where we're going for a meeting in, I think, 2 meetings time. We'll be there, so glad to see that the Belfast team is over here. They were getting a few missed scans due to people having high glucose. So they made a couple of changes, moved from, instead of a 6-hour fast, they moved down to a 4-hour fast, and instead of having a cutoff of 10 in their blood glucose, they moved to 11. It sounds like they were on the margin, so there was a couple of patients showed muscular tracer uptake, but nevertheless all of the scans were diagnostic, and they had fewer missed appointments. So again, it's questioning what you do and can we do better for our patients. So this is gallium again, and this is a nice labeling kit that Kings have been working on. So it's got a simple preparation method, good labeling, and there's a promising red blood cell labeling kit for GI blood loss or blood pool imaging. So it's nice to see a radiopharmacy thing in here. And I've put on this old school nuclear medicine. It's not, this is our kind of, what, we've been doing lymphocytograms for years and years, and they sometimes get forgotten with the kind of PET talks and the whole body bone talks and the theranostics and everything else. But nevertheless, patients need our help, and this is something that we should be trying to do, and not just do, we should be thinking about and trying to do better. And there's some nice data here, big numbers, and they're comparing the clinical assessment with their lymphocytogram findings. So it's good to keep pushing and evolving all of the different studies we do. In nuclear medicine, we have a real benefit in diagnostic nuclear medicine of the variety of different teams and patients that we can help. And we should try and keep those broad tests going so we can keep helping people with these great examinations. So that's the end of my little snippet. There's plenty of other posters there. I'd like to thank all the poster authors for all the effort you've put in and the extra effort you've made to share the work for everyone's benefit. I'm sorry I can't show more posters, but they're all there, and in the next session you might have time to nip around a few of them, and if that's piqued your interest, you can go and look for more detail. You can go and check that I haven't completely missed the point of the poster, but yeah, be kind. Thank you very much.
So Stuart, thank you very much for that really enlightening talk. And it really shows you the diversity of things we've got going on here at our meeting and some wonderful posters there. And I think you could potentially start a new focus group on bringing back gallium imaging to the NHS.
Yeah.
So anyone who wants to be involved in that, see Stuart afterwards. So no, really well done and thank you very much.
Thank you.
Each of us hearts and